What are the challenges for families? Despite efforts to keep placement in a residential program geographically closest to where the child's family lives, clearly communicating to families. I mean, we have the families sign kind of a contract that they understand they need to participate in family therapy and they need to participate in interventions with the SIPP facility. A lot of times it doesn't happen because the families have transportation problems. These are real world problems. They don't have cars, or they don't have the financial resources to be able to pay for gas to go 40 miles away. They may not drive. So there's a lot of real life challenges that families face. And there is data that about 12% of SIPP enrollees had no family visits. So that becomes a challenge. And the reason I put that in is because the children who are community kids are coming out of SIPP and going back to the families. And there has not been a lot of change when they're returning back to the families. And a lot of times the same problems start creeping up and the children decompensate. So now they are in SIPP, and to talk a little bit about what happens when they're coming out of SIPP. And we are also getting kids, like I said, working for Camelot. Kids are getting stepped down, and then they're coming into the therapeutic foster care. Discharge planning begins at admission, ideally. The community case manager could stay involved throughout the residential stay of the child. Do all SIPPs have community case managers that are involved, that stay involved, or no? Jails are only dependent kids.
Yes, the targeted case managers, there should be.
Yeah.
They can be funded for 180 days.
That's the other barrier. The problem is that they can, I guess, bill for 180 days, but then sometimes the SIPP stay is not 4 to 6 months. Sometimes it's 12 and 13 months. So then
it's justifiable, the duration, like just after the 180 days?
No, it's not.
We will pay.
Oh, you'll
if
pay.
It's above the 180 days, it's justifiable and it's documented why the kid is still there.
You'll pay for case management?
Yes.
Okay. Because I was talking to one of the case management supervisors, and from what I heard, it's like, no.
They don't get it.
They don't do it. It's not until
Yeah.
they can.
Okay.
They don't know that.
They should know it, but that doesn't mean they do.
So it just needs to be documented, and then they can.
Okay. So then what happens is, if they kind of have an idea that the child is probably going to stay longer because they're not really progressing well, then they back off. So the case manager says, contact me when the child, about 30 to 60 days prior to discharge. So that's pretty much what happens, is 30 to 60 days prior to discharge, the case manager is contacted for discharge planning, and then they get like a packet of information. And this is, I'm talking about community kids. Now there's a whole other set of planning that needs to be done for dependent kids, because usually when a dependent child is going into a SIPP, they're probably not returning back into the same foster home. So they're going into a different foster home. So from my Camelot perspective, the Camelot, the team leader, what they are trying to do is, okay, let's try to match a family. And how long am I going to keep the bed open? Because this home, yes, we can keep it open for maybe a couple of weeks, but we cannot keep it open for 4 months. So that pressure kind of, even they match and if the discharge is delayed, then that kind of falls apart. So there's a lot, the discharge planning is, like I said, ideally it can start from admission, but does it practically happen? Because these are the barriers, and then the child is discharged into a home that they may have had 1 or 2 contacts with the parent, the foster parent. So that's the dependent kids, the placement issues. Continuity of care, linkage with psychiatric, behavioral health, appropriate educational and other services, all that needs to be done. Sometimes I find that it's also happens that perhaps the parents didn't understand the instructions, the child is running out of meds, it becomes kind of like a crisis or an emergency, the child is out of meds. Dr. Stock was mentioning about a child that was released on Clozaril. I find that too, and there's any special medications such as Clozaril or Depo, neuroleptics. Occasionally we've had kids on a, Risperdal Consta or a Haldol deck, and then there is a little extra planning that needs to be done. in terms of discharge planning.
So the kids showed up and the family didn't know anything about blood draws, so no mechanism had
Exactly.
On a Friday afternoon, I'm like, uh-oh, what, kids out of medicine, how am I
Right.
gonna get a blood draw and a prescription? It's a mess.
Right. And that has happened to me a couple of times also. And one time I had to call ChildNet and arrange for a home health nurse to administer the shot, because it was, it's a therapeutic foster care Camelot. I don't have the ability to give shots in the office. And I had to, kind of get special funding to get a Maxim to come in and do the shots. So there is a little extra planning that needs to be done. And sometimes those things are really not thought of, and it's just the child is out and the community provider really needs to figure this out sometimes in a day. So what are the challenges? Some of the challenges are, of course, like you at your end, we at our end need pertinent and current treatment information. For example, the discharge packet that the case manager gets could have information that is 30 to 60 days old, and they'll have it in the chart, and when the psychiatrist has the appointment, for example, the community kid comes back home, and then they come to the community psychiatrist, and then you're looking at the information, and you have treatment plans. They're good, but what I need really is maybe the last progress note from the psychiatrist, and the psychiatrist's last medication profile. Labs, we definitely don't get labs. And we need to have labs. And if the labs were done, if there's Depakote level or even lipid profile, anything, the lab results are never there. So copies of physical exam reports. One time I had a child who said he was having seizures when he was in the SIPP program and had seen neurologists. Well, we never had any of that information. We had no neurological evaluation reports. So none of the pertinent medical stuff is really, I don't think that attention is paid that much in the discharge packet. Consent-related documentation for dependent kids. That sometimes is a big problem, because we don't, sometimes you get a court order with the doctor's name that is in the SIPP. And of course, it is what it is. Sometimes we don't even get that. We don't get documentation on approval for multiple meds. For example, now we need to have that whole process with UF. You have the kids on more than one medication. You have to have a pre-consent, and the pre-consent documentation is not available. Sometimes people don't even know that there is that kind of a process that needs to be in place. Parental signatures. You get a signature that may not be in that 10-page form. Sometimes
It should be. There's a
Yeah.
page in there.
I don't know if it is uniformly being used in every.
Uniform form. I
There's
don't know
a
that everybody
uniform
uses
form,
it.
but I know that Miami-Dade is very resistant to use the correct.
I know, we don't always get it.
Very much.
Yeah.
Right. Other challenges, child being on multiple meds, high doses, and unusual meds. Sometimes, you get some unusual meds. Special meds like clozapine, not having paid attention to the fact that, labs need to be done. Again, not getting the labs. What is the frequency of the labs that the child is currently on? Is it once a week? Is it every other week? If the child had been there in a SIPP for 14 months and had been on Clozaril for, say, 8 months, maybe they're on a 2-week lab cycle, but not knowing that kind of information. Insurance issues is a big issue for the community psychiatrist, because a lot of these kids who are in a SIPP, you're not billing Medicaid for medications. It's bundle rate. Am I right? So when it's a bundle rate, then they come out and they go to the pharmacy with the prescription, because you're discharged with a script. They go to the pharmacy with a script for Abilify, and it's not covered. So now they don't get it. And they're calling me, and I have not seen the kid yet. And, oh, the kid just got placed, and kid is on Abilify, and Abilify is not covered. Okay, so what am I going to do now? What do you want me to do now? Well, we have to figure out a way. Do we do PAP? Do we do, prior authorization? Do I scramble for samples? Or can you find some flex funds to pay for it for at least a week until I get there, so I can figure out what to do next? So that becomes an issue. The insurance issue does become an issue. And for community kids, they may not even have insurance sometimes. And so they're like, okay, I have Abilify, and how am I going to pay for these? And that becomes a challenge because it's not about PAP, it's about really long-term planning for meds, and we do the patient assistance programs, applications, and here, work with the case manager to apply for insurance. Sometimes maybe they cannot apply for insurance because they don't have a green card, and so then they are not eligible for Medicaid. So what do we do? So that becomes a challenge, and the planning part has not happened, and it becomes more of a crisis. And I am also asked for court order requests for discharge meds. So kid is coming out of SIPP and is on 600 milligrams of Zonegran and 600 milligrams of Seroquel, and then the caseworker has left this request for court order, and the staff member is telling me, oh, they want you to fill this form to get a court order. Okay, they want the court order for the new psychiatrist. I mean, I don't even know. I'm just writing it down as discharge meds, but then it becomes laborious that you have to justify it, and we do. But again, that's a challenge. And the challenges from parents could be the meds are not working. And we hear that a lot. We hear that sometimes saying, oh, because a kid comes back, maybe they are stable for a couple of weeks and they get back into the same environment, or they're not taking their meds consistently, or there are side effects. There are sometimes significant side effects such as weight gain or galactorrhea, and they haven't menstruated in the past 4 months, and now suddenly they're telling you, oh, I haven't had my period in 4 months, and meds are not working. So that becomes a challenge too, because there's request for med or dosage changes by the parent. And issues related to treatment adherence, kids who go into SIPPs, I'm sure many of them have not been taking their meds consistently before they come in, and then they come out. And many of them are not taking their meds consistently because the parents are not monitoring, they're not supervising, they're asking the kids to take the meds themselves, and there is irregular adherence. And of course, children returning to the same living environment and family dynamics not changed. And so these are some of the challenges. And that's it.